We have been called first thing in the morning to the house of a 52-year-old male who, for the past week, has been experiencing 3 out of 10 upper left and upper right quadrant pain with a burning sensation. This pain also bands to his back, and over the past 12 hours, his pain has worsened to a 9 out of 10 and has been vomiting because of it. As we sort of continue to speak with our patient, we discovered that his last bowel movement was 3 days prior, which had very small and dehydrated fecal matter to it, but there was no blood in his stool. What we know about our patient is that he's taking medications for either GERD or for peptic ulcers, but we aren't sure at this point. He's also taken Tylenol for pain improvement to have received very minimal pain improvement, but this could also be covering up a fever. We haven't decided yet. We know that our patient chronically uses ETOH, is also a smoker, and has a very cholesterol-rich diet. He also has a history of diverticulitis, but he tells us that he's never experienced this type of pain before. We have taken a quick set of vitals, and we're going to quickly breeze through those before we continue on with a focused assessment. Our patient's experiencing hypertension, and this could be secondary to his lifestyle, as well as it could be elevated as a natural pain response. He's not experiencing any tachycardia at the moment, which is surprising given the pain that he's describing to us being 9 out of 10. His BGL is on the lower end of normal, but this is consistent to someone who's woken up, hasn't been eating much in the past few days, and probably hasn't had breakfast yet. His temperature is within normal, but again, we know that he's taken Tylenol, and we aren't sure if it's masking any type of fever. His work of respiration is elevated, again, could be a natural pain response, as well as he's also explained to us that deep inspirations cause him a lot of pain to his upper quadrants of his abdomen. So, given his position, his mentation, as well as his skin condition, hypoxia isn't really a concern at this point. So, knowing a brief history and vitals that we've taken on our patient, we can sort of start to think about our differential diagnoses. Our first one, of course, being a myocardial infarction. This is due to the risks of his age, as well as him being a smoker, as well as ETOH use, as well as a high cholesterol diet with hypertension. He's also experiencing back pain, epigastric pain, and has been quite nauseous and lightheaded. So while we continue on with our differentials, I'm going to ask my partner to quickly run a 12 lead on our patient so we can interpret it later before we continue with our assessment. Our second differential is going to be a AAA. Again, risk factors include hypertension, as well as his age, as well as a high cholesterol diet. And signs suggesting this could be the pain that he's experiencing to his high abdomen that bands around to the back. However, the burning pain that he's describing doesn't quite align with the typical immense shearing pain that patients often experience when they're having a AAA. Because it's also a life-threatening condition, we're going to have our partner take a bilateral blood pressure on both of our patient's arms. And what we're looking for a positive sign is going to be a change of 30 millimeters of mercury difference between the two arms. While my partner works on that, we'll continue on with our next differential, which is Crohn's disease. This could be what's causing our patient's potential constipation, as well as causing pain that occurs to his upper quadrants an hour and a half after eating. However, our patient has no history of Crohn's disease, as well as he's describing anterior abdomen pain, which does not typically coincide with the posterior abdominal pain that you would experience from your transverse colon. There's also been a lack of blood in the stool, and so these are a couple pertinent negatives to Crohn's disease. However, we're still going to keep that in mind as we continue our assessment. Our next one is going to be biliary colic, and this is just due to our patient's risk factor of ETOH use, as well as a cholesterol-rich diet. He's experiencing a burning type pain that occurs an hour and a half after every meal. And so this could be typical to some form of duct block caused by a stone that's developing somewhere. We're unsure if there was a fever in place just because our patient has taken Tylenol prior to our arrival. He also explains that deep respirations increase the pain that he's experiencing to his upper right quadrant. And so this could be a soft indication that we have to dig a little bit further with biliary colic. Lastly, our final differential diagnosis is going to be pancreatitis. And as we will later find out with our inspection, we are going to find Cullen's sign, which is bruising superior to the umbilicus, which is a really strong indication towards pancreatitis, as it indicates that there's pancreatic juices that are leaking out and affecting and digesting the vasculature of the peritoneum. He's also experiencing left upper quadrant originated pain that also bands to the back. These are some good signs of acute pancreatitis, and so we're going to keep this in mind as we form our working diagnosis. At this point, before we continue, our working diagnosis is going to be acute pancreatitis, but possibly secondary to biliary colic. And our reasoning for this is going to be upper left and upper right quadrant pain that elicits a burning type sensation after an hour and a half after eating a meal. This could be due to a stone blocking the ampulla of Vater, which would be capable of backing up bile into the gallbladder, as well as pancreatic juices back up to the pancreas. So at this point, we're going to return back to our patient and hop into our focused abdominal assessment. Hi, sir. I see that my partner has been taking some blood pressures off of you, and we also have some cords hooked up to your chest to take a picture of your heart, okay? At this point, I understand that you're experiencing some epigastric pain, and I'd really like to go into a more focused assessment. And what that's going to ask of you is I need you to lie on your back, and I need you to expose your abdomen. I'm going to be listening with my stethoscope. I'm going to be taking a good look at your abdomen, as well as I am going to be poking at it. I don't want to cause you too much pain, but I do have to get a better understanding of what's happening today. Does that make sense to you?
Yes, it does.
Are you okay with us proceeding with that?
Okay, I am.
Perfect. Okay, I'll just get you, I'll have you get comfortable. And while my patient's getting comfortable, I'm also going to be watching him for some sort of pain response like he just elicited there. While he's also getting in position, I have results. I would have gotten results for my bilateral blood pressures, as well as I have also gotten my ECG from my partner, and I've interpreted it as being normal sinus rhythm. And so at this point, I'm very confident in ruling out a myocardial infarction at this time. Okay, so moving on. Is it okay if I put my hands on your abdomen while I conduct my assessment?
Yes.
Excellent. So I'm just going to further expose the abdomen a little bit more. And really, there's a few things that I'm looking for when I visualize his abdomen. One is going to be ascites, one is going to be distension, one's going to be rigidity of the abdomen, as well as I'm going to be looking for any asymmetry, as well as any discoloration. If I'm seeing full yellow discoloration, it would be indicative more of a liver disease. But upon looking at my patient's skin condition, as well as the skin of his abdomen, I don't see any jaundice at this point, and so liver disease was never really sort of one of the working diagnoses. However, I am seeing some some light yellow, some dark yellow bruising superior to his umbilicus, which we know as being pollen signs, which is a good indication towards pancreatitis. Our abdomen is symmetrical in nature. I'm not seeing any ascites at this time, and when I, as well as, sorry, just give me a second. But we are seeing some bruising, as we said. So this is a good point to, oh, sorry, totally forgot. We're also looking for pulsating masses because we're also querying an abdominal aortic aneurysm. At this point, I'm not seeing any pulsating masses, so I think it's going to be safe to move on to our next focus assessment, in which I'm going to auscultate the 4 quadrants of my patient's abdomen. Typically, we will be auscultating for a minute in each quadrant, and what we're really listening for is we're going to be listening for any bounding pulsation, and we're going to be listening for bowel sounds. Bowel sounds, to me, is going to tell me that our patient isn't constipated as much as he is just avoiding food due to the pain that it's been causing him lately. If there's no constipation, it might be a good sign to further rule out Crohn's disease from our patient's diagnosis. We're going to be listening for any pulsations and any bounding pulsation, which could be an indication of worsening aortic aneurysms. At this time, we'll be performing our auscultation beginning in the right lower quadrant, moving up to the right upper quadrant, across to the left upper quadrant, and down to the left lower quadrant. We don't know the exact results of this assessment, but again, we're listening for bowel sounds to rule out Crohn's disease, and we're hoping not to hear any bounding pulsations so that we can further rule out AAA. Moving on, it is going to be a percussive exam. However, given the nature of our 4 working differentials, I don't believe that there's going to be any percussive indications that further support any of my working diagnoses. We're going to retain nothing for pancreatitis. We won't retain anything for biliary colic or cholestasis. We're not really going to get anything else for Crohn's disease from percussing, as well as we're not going to be measuring anything along the lines of a AAA by percussing the abdomen. So understanding this, we're going to move past that and we're going to move on to the palpative examination. So this is the point of the assessment where I told you at the start we're going to be poking a little bit. I'm going to try and not cause too much pain, but just understand that your pain response is going to help me further understand what's happening with your abdomen today. Is that okay? Are you ready to start it? It's going to be light at first, and then after we're done a light assessment, we're going to do some deeper palpations. Okay? Excellent. So this is the point where we're lightly palpating across the abdomen. And what I'm feeling for is I'm feeling for any distension, any rigidity, and I'm also looking at my patient to see if it elicits any form of pain response. This also helps me understand if he was to elicit a pain response. It helps me understand how my patient is interpreting his quadrants of his abdomen versus my knowledge of his anatomical quadrants of the abdomen. So now that our light palpation is complete, we're going to move on to deeper palpation. So I'm going to let you know now that this might elicit more of a pain, but again, it's just sort of something we have to do, and if it's okay with you, I'd like to proceed. Okay, excellent. So I'm going to start away from the region of pain. So I'm going to start down in his lower quadrants, beginning at his lower right quadrant across to his lower left. All right. And so there's a few things that I'm observing for. One of them being any distension or any masses that could indicate to me any kind of bowel obstruction due to constipation, which would better support our differential diagnosis of Crohn's disease. What I'm also feeling it for is any deep but bounding pulsating masses. To me, this would indicate a AAA, and this is going to be a good time for me to take my hands off the patient and get him in a position for rapid transport to a hospital. Now that we've assessed the lower quadrants, we will move up to the upper quadrants. And due to the nature of my working differential, I'm going to be starting at the left side, working across to his upper right quadrant. Okay? I'm watching for a pain response. I'm watching for a pain response upon palpation, and I'm also looking for any pain response due to rebound tenderness. There's no signs of rebound tenderness at this time, but we're also going to, hold on. Masses, stop, rebound tenderness, 9% pain. Okay, so we might see some sort of pain response as we prod at the upper left and upper right quadrants, especially the upper right quadrant due to the anatomy of where his gallbladder is going to be located, as well as his pancreas. It might elicit a pain response, but it also might not. Mainly, we're just looking to ensure that there's no rebound tenderness, which would hint towards any organ laceration or perforation. So at this time, I think it would be best to move on to a more focused examination, especially because I'm thinking that you might be experiencing some gallstones today, or possibly acute pancreatitis, where the pancreas is essentially kind of digesting the area around your abdomen, which is causing you some pain today. So there's one test I would like to do, and it involves me placing my fingers underneath your rib cage, and I'm going to have you exhale while I put my fingers under, and then inhale deeply. Okay?
Okay.
Are you ready?
Inhale.
Exhale.
Okay.
All right. And inhale when you're ready. What I'm looking for, this is the Murphy's test, and we're looking to see if we get a positive sign or pain elicitation upon performing this test. What this really proves to us is there's some form of inflammation occurring to either the gallbladder or to the bile ducts, and this would really solidify our working diagnosis of biliary colic at the very least. We don't know if our patient has a fever due to the Tylenol, so it's kind of hard to rule in or out cholecystitis, but knowing that there's biliary colic is definitely a good start. And now to review what we've done along the way. Oh, thank you. We can cover up your belly now. You just stay comfortable, okay? So to review, we've done a couple special examinations along the way. We've done bilateral blood pressures since we're querying a AAA. We've done a 12 lead because we're querying MI. We've auscultated and palpated the bowels to assess for the possibility of Crohn's disease and it causing any constipation. We've noticed colon signs as well as nausea and vomiting after eating and a wrapping pain to the back, which is a good indication towards pancreatitis, as well as we've done the Murphy's test to further confirm our suspect of biliary colic. That's all. Treatments, I believe that our patient is suffering acute pancreatitis secondary to biliary colic. I believe that treatments hereafter should possibly involve some fluids, giving some ketorolac for pain without inducing spastic contractions of the biliary ducts, and possibly ondansetron to inhibit the vomiting without draining the stomach contents into the intestinal tract, which we would with Maxran. We would be ready for oral glucose or some other caloric agent due to his low BP, or low BGL, pardon me, as well as having oxygen saturation, as well as having oxygen supply due to his lowered oxygen saturation. We'll be transporting the patient to the hospital.